Good afternoon, everyone. My name is Andriana Zoupou, and I'm the Business Unit Manager for Relife in Greece. I would like to welcome you to the global meeting of experts in dermatology, and thank you for their attendance despite the difficult situation we are all facing due to COVID pandemic. This webinar is dedicated to dermatology portfolio of Relife, and we are honored to have here with us distinguished international experts that will shed light to several skin conditions, such as atopic dermatitis and eczema, hyperkeratosis, hyperpigmentation, and acne. I would like to thank our experts for sharing their valuable knowledge, as well as all of you for joining us today. Now, before we begin, let me introduce you Menarini. Menarini is one of the most historical and well-established biopharmaceutical companies in Europe. It is a multinational company with headquarters in Florence, which is the cradle of Renaissance and cultural center of the world. Menarini was founded 130 years ago, and all this time has managed to follow a consistent and solid expansional strategy, both in terms of geographical expansion as well as R&D and pipeline. Regarding geographical expansion, the milestone I would like to emphasize is 1960s, where Menarini decides to go global, and so far it is present to most parts of the world. Now, regarding the therapeutic areas of focus, I would like to highlight the year 2017, when Menarini decides to invest in dermatology and aesthetic medicine, and we have the beginning of Relife. Now, Menarini expanded its international business very rapidly, both in terms of turnover as well as personnel. It is a growing business, and it's worth to mention that 75% of revenues comes from international markets. Also, Menarini is one of the companies with the highest share of voice, since we are counting more than 17,000 people worldwide. That means that we have the capacity to support our products and all of you in your countries with the best possible way. Menarini is not only the biggest Italian company, but also has a very important role in the global setting. And that is also translated to the level of innovation, of scientific evidence, and educational support that we offer to our HCPs worldwide. In terms of ranking, Menarini is number 11 in Europe and Asia Pacific, and number 35 in the globe. Now, coming closer to the market I represent, which is Greece, Menarini is number 12 in the total pharmaceutical industry and number 1 in the markets we serve, that is, the therapeutic areas that we have presence. Furthermore, we have a very strong presence all over Greece, with more than 250 employees around the area, 169 out of them being field force. That means that we are doing our best to support the medical community. Now, let me share with you a few words about Relife. Relife is a new company that has its roots in Menarini Group. Now, being an Italian company, as well as being a company that focuses in dermatology and aesthetic medicine, is driven by 3 main values: science, art, and perfection. Now, science, because Relife is leveraging the scientific heritage of Menarini and focuses on scientific evidence. Art, because it is driven by aesthetic approach of very high standards. And perfection, because we are aiming to a healthy, beautiful, perfect skin. So bottom line, our vision is to create beauty and natural perfection based on scientific rules. This balance among science and art is also depicted in our logo, Relife's logo, which is inspired by Leonardo da Vinci's Vitruvian Man. And of course, this devotion to innovation and science results to high quality products that you can trust. Now, Menarini has expanded its global presence very, very rapidly. It started 3 years ago from Italy, and now it is present in 2 continents, Europe and Asia Pacific, soon to be in 18 countries, with 18 SKUs for medical aesthetic and 21 for dermatology. And of course, there's more to come, since there's a very strong pipeline that follows, and also new countries to launch. Now, allow me to say that as we speak, It is Greece that's launching the dermatology portfolio of Relife, and from this week and onwards, the products are available to the Greek market. Speaking about portfolio, allow me to share the integrated portfolio approach of Relife. So Relife is based in two main pillars, dermatology and aesthetic medicine. Now, these two pillars are not meant to be independent, but they're aimed to work synergistically and complementary in order to achieve best patient outcomes for our patients, best outcomes for our patients. And now we truly believe that with this integrated approach, we can target beauty in an holistic way. We can help people have a beautiful, natural, healthy skin, and also achieve inner and outer well-being. That is why in Relife, we believe that my skin says how I feel. Now, having said all that, I would like to thank you very much for the attention, and I would like to give the stage to Professor Aimilios Lallas, who is an Associate Professor of Dermatology in Aristotle University of Thessaloniki. He's a very well-known dermatology expert and an international key opinion leader for dermoscopy and skin cancer. So, Professor Lallas, the floor is yours.
Good afternoon, everybody. I'm not sure if it's afternoon for all of you because I was just informed that we have something like 1,000 participants from practically all over the world. So for some of you, it's not afternoon, I guess. So welcome in this live webinar. First of all, I would like to thank very much Menarini and Relife for organizing this event. As you probably already saw from the agenda, we have quite a rich scientific program, and we have some recorded lectures, but we will also have live discussions, which I hope that will be vivid and interesting. Practically, we have separated the event in two parts. We will have a live discussion in approximately 30 minutes from now, concerning the first three lectures, and then a second discussion in the end of the event. Throughout the event, at any time, you can send your questions in the chat, and I will try to moderate as many of them as possible to be answered by the speakers. So I think that we can start. Let me present our first three speakers. Which are first Stamatios Gregoriou, Associate Professor Stamatisis in Athens, in the University of Athens. His topic will be atopic dermatitis and disease burden. Then Adelaide Ann Hebert will follow, who is a professor of dermatology and pediatrics at the McGovern Medical School in Houston, Texas, in the States. And after her, the third talk will be by Giovanni Pellacani, who is also professor of dermatology in the University of Modena in Italy, and he will speak about evidence-based management of atopic dermatitis and contact dermatitis. So the three talks are somehow associated one to the other, and I think that we can have a nice discussion of all the three together immediately afterwards. So I think that we are ready to start with the videos, and we will be back live with the three speakers, of course, in approximately 30 minutes. So I hope that you will enjoy the videos, and we can start with the first one.
Hello to everyone. I'm Stamatios Gregoriou. I'm an Associate Professor of Dermatology and Venereology at the National and Kapodistrian University of Athens. Welcome to this Relife Symposium, and this session is going to focus on atopic dermatitis and disease burden. Atopic eczema is a chronic, itchy, inflammatory dermatosis. It affects both children and adults. It manifests with an acute phase that is characterized by erythematous patches and vesicles and blisters, and the chronic phase that it usually is characterized by dry skin and lichenification. The main immune response mediating atopic eczema is a type 2 inflammatory response. The primary cells involved include Th2 cells, innate lymphoid cells type 2, mast cells, T follicular helper cells, basophils, and eosinophils. And the key cytokines are IL-4, 5, 13, and 31. Now, this response is normally driven by allergen and parasites, but when involved in a dysfunctional immune pathway, it mediates type 2 inflammatory diseases. These include atopic dermatitis, allergic rhinitis, asthma, nasal polyps, eosinophilic esophagitis, and food allergy. The expression of type 2 cytokines in adult skin biopsies of patients with atopic dermatitis correlates with disease activity. And we can see that all the main cytokines, IL-4, 13, and 31, are not just increased in acute atopic dermatitis, but also in non-lesional skin and chronic atopic dermatitis. IL-4 and IL-13 not just mediate the immune response, they also affect qualities of the epidermal barrier. They downregulate keratinocyte terminal differentiation and expression of epidermal barrier proteins. And many cytokines such as TSLP, IL-33, 4, and 31 also interact with sensory neurons to create itch perception. They also affect stratum corneum lipids and filaggrin reduction. Chronic lesions are also characterized by a type 2 immune response, but they also have a Th22 signaling and an increase in type 1 signaling. The prevalence of atopic dermatitis ranges between 2 and 10% in different regions, and most of the cases start in childhood. And although we do know that Northern Europe has a high prevalence of atopic dermatitis, Central and Southern Europe also have significant prevalence of atopic dermatitis, and in some studies, it is suggested that this prevalence might be even higher than Japan, Canada, and USA. Most of the cases are mild or moderate atopic dermatitis, with severe atopic dermatitis ranging between 3 and 8% of the cases. Patients with atopic dermatitis also have type 2 comorbidities. They have a 33% greater risk to present other atopic disorders, and when considering adults with atopic dermatitis, about 3 out of 4 have also at least one atopic comorbidity. These include allergic rhinitis, asthma, and food allergy. Atopic dermatitis and food allergy start earlier in childhood, while asthma and rhinitis come along later in childhood. This has been described as the atopic march. Severe atopic dermatitis coexists even more often with other atopic disorders. In patients with asthma, atopic dermatitis is more often severe than mild or moderate, and the same holds true for patients with food allergies. Atopic dermatitis is intermittent and has flares. Patients declare that they are often worried and nervous about the next flare and feel helpless to prevent it. In patients with moderate atopic dermatitis, they have flares for more than a third of the days of the year, while patients with severe atopic dermatitis have flares for more than 6 months per year. Pruritus is the main contributor in the quality of life of the patients with atopic dermatitis. When considering the frequency of pruritus, 9 out of 10 patients declare that they have pruritus for the whole week. When considering severity, 6 out of 10 describe it as either intense or unbearable. As for the duration of each, 3 out of 10 declare that they have pruritus for 24 hours a day. It affects daily activities and even more so sleep. And when considering childhood atopic dermatitis, sleep disturbance might also affect the quality of sleep of the parents. It also affects social activities, household activities, work and study. The impact on health-related quality of life is even more increased in severe disease, and this is evident by both general health quality indexes as well as dermatology life quality indexes. It also means that patients have decreased productivity and they make increased use of health resources. The health-related quality of life of patients with atopic dermatitis has been suggested to be similar to that of patients with psoriasis. The guidelines of the European Academy of Dermatology and Venereology suggest the use of emollients and bath oils as baseline therapy for atopic dermatitis, regardless of severity. That means that more severe cases needing pharmacological therapy should also make use of emollients and bath oils. It also mentions that there is an unmet need for high-quality emollient therapies that should be affordable. The frequent use and the quantities required by both children and adults with atopic dermatitis mean that if the cost is not affordable, poor adherence in the use of emollients will be the result. And I have to thank you for your attention.
Welcome to New Horizons in Pediatric Dermatology Disease. I'm Dr. Adelaide Ann Hebert. I serve as Chief of Pediatric Dermatology at the McGovern Medical School in Houston, Texas. Today we will discuss atopic dermatitis in terms of current advances. We will also look at the advances in terms of influencing patient care and the current guidelines of care for atopic dermatitis. We recognize that greater understanding of the pathophysiology will help us with using the emerging therapies to the greatest advantage in patient care. Here are the guidelines from the United States. Note that the use of moisturization is recommended across the full scope of atopic dermatitis disease. If we look at the European Task Force in atopic dermatitis, we also see that the cornerstone of therapy is using a moisturizer daily, irrespective if your atopic dermatitis is mild, moderate, or severe in nature. As we go on looking at the pathophysiology of atopic dermatitis, we see the many influences: the barrier defect, genetic predisposition, the environment, and so forth. Indeed, if we see, as depicted here in this patient, the barrier defect is really a cornerstone and an initiator of the pathogenesis of atopic dermatitis. We recognize that the skin barrier really manifests as an increase in transepidermal water loss and, unfortunately, the increased penetration of allergens and infectious agents that act as triggers for this disease state. These contribute both to inflammation as well as pruritus. We recognize that the classic concept of atopic dermatitis talks about the trinity of the barrier defect, allergy, and pruritus. We also know that this interplay results in influence of upregulation of inflammatory cytokines and further destruction of the barrier itself. We also know that inflammation can be acute, subacute, and chronic. We see increased pro-inflammatory cytokines in atopic dermatitis, which include tumor necrosis factor, interleukins such as IL-4, IL-9, and IL-22. We have many other cells, including plasma cells, mast cells, eosinophils, B and T lymphocytes, which play key roles in this inflammatory process. So we look at the role of oxidative stress as a new construct with regard to various disease states in the realm of medicine. We have long known that we can implicate oxidative stress in cardiovascular disease, diabetes, neurodegenerative inflammatory diseases, as well as cancer. Oxidative stress in atopic dermatitis is a more recent concept which has been recognized. We know that oxidative stress plays a key role in worsening the barrier defect in atopic dermatitis. Therefore, we really want to focus in the future on means to reduce this oxidative stress and repair that barrier disorder. We are able to do this by recognition of the oxidative stress as really being an important factor in the pathogenesis of atopic dermatitis. Why is oxidative stress important? Well, there is damage to cellular structures, there is resultant inflammation, and again, defects in the skin barrier which warrant repair. We know that oxidative stress in atopic dermatitis has really been in the medical literature for at least 28 years, but has really come to the forefront more recently as we better understood the pathogenesis of this disease state overall. We also know that oxidative stress promotes tissue inflammation because there is upregulation of inflammatory cytokines. These inflammatory cytokines release free radicals. So oxidative stress thus plays a key role in atopic dermatitis. We also know that oxidative stress can actually be due to factors such as environmental issues, physical, emotional, psychological issues as well. Now, air pollutants, tobacco smoke, volatile organic compounds, formaldehyde, and other agents may also relate to oxidative stress within the realm of atopic dermatitis. We recognize the role of oxidative stress in activating NF-kappa beta pathways, which lead to gene expression and synthesis of antioxidant enzymes in the skin. This resultingly can cause direct damage to epidermal keratinocytes by DNA damage, damage to cellular enzymes, and damage to cell membrane structures through lipid oxidation. Thus, we really want to recognize the important factors implicated in the pathogenesis and outcomes related to atopic dermatitis. And I've listed these for you here, including environmental as well as other factors which play key roles. Now, we have come to recognize an important scientific rationale to actually use an emollient device enriched with antioxidants when one is caring for a patient with atopic dermatitis. This particular publication really cites a unique agent which contains furfuryl palmitate as part of the emollient device. Again, furfuryl palmitate in an emollient has been cited in this particular article looking at the therapeutic benefits and enhancing the permeability barrier for those suffering with atopic dermatitis. We also recognize that emollients with antioxidants really do have a scientific basis in improving the skin barrier, and this guide, published in the Asian literature, references exactly the use of new agents such as those containing vitamins and furfuryl palmitate in the improvement of the barrier by use of emollient devices enriched with antioxidants. We know that these are innovative processes in the overall strategy in managing atopic dermatitis. These emollient devices, particularly those with antioxidants such as furfuryl palmitate, really do have an impact in reducing inflammation and effectively restoring the skin barrier. Recently, I have also published in the International Journal of Women's Derm how oxidative stress really must be focused on as a treatment target in managing atopic dermatitis fully and effectively. And I also cite the use of furfuryl palmitate in the emollient devices to treat mild to moderate atopic dermatitis. Now, we know that oxidative stress plays a key role in the etiology of atopic dermatitis. So addressing it and treating it effectively really become paramount as part of our therapeutic strategy. We also recognize that if we use these targeted therapies, such as emollient devices containing furfuryl palmitate, we can really restore the barrier and favorably impact the overall outcome of atopic dermatitis management. We've also looked at other targeted treatments, including furfuropalmitate or its derivatives, which can be effective in using agents such as emollient-based targeted agents to reduce the need for steroids, particularly topical steroids, when managing atopic dermatitis. So, in summary, what we really recognize that topical antioxidants can be used very effectively in managing atopic dermatitis. These targeted agents, such as furfuropalmitate containing emollient devices, really can benefit our patients overwhelmingly as we manage their disease state. So in conclusion, while we recognize that atopic dermatitis remains a challenging condition both to understand as well as to manage, if we recognize the role that oxidative stress plays in managing atopic dermatitis, we can find new agents for barrier repair. There is a new generation of prescription emollient devices that are enriched with agents such as furfuropalmitate, a topical antioxidant, which can truly reduce oxidative stress in those patients suffering with atopic dermatitis. We want to look next at new therapeutic horizons in the management of diaper dermatitis. We recognize that diaper dermatitis, which is also called diaper rash or nappy dermatitis, is one of the most common disorders that we see of the skin involving both infants and toddlers, those who wear diapers. There have been several technological advances recently in both diaper design and other components that lessen the severity of the diaper dermatitis findings. However, due to the unique environment of wearing a diaper, children and adults who wear diapers continue to have a current challenge related to diaper dermatitis occurrence. We recognize the four main pathophysiologic components in developing diaper dermatitis. Of course, we have irritation, a natural skin barrier defect because of the diaper, we have inflammation, and microbial contamination. What we want to think about in terms of benefiting those patients suffering with atopic dermatitis is a barrier cream, such as found in zinc oxide, a repair cream, such as one with dexpenthanol. We also want to think about anti-inflammatory properties, such as taurine, and the antimicrobial properties provided by zinc gluconate. There can be some very important clinically evidence-based paradigms using certain formulations, particularly those that contain both zinc oxide, dexpenthanol, taurine, zinc gluconate, almond oil, and these are all found in the Melasma baby care and the Melasma spray and go. These have been effectively evaluated and shown to have good dermoprotective efficacy. They can reduce the erythema, and they have good cosmetic acceptability. We actually have clinical studies on infants aged 3 to 36 months with Fitzpatrick skin types ranging from 1 to 4. There was some slight irritation in the diaper area as determined by board-certified dermatologists and pediatricians, where this product was considered clinically effective. We look at this evidence-based paradigm, and we see both Melasma baby care and Melasma spray that can effectively reduce the erythema in the toddlers and infants who suffer with diaper dermatitis after just 2 weeks of application. We also recognize those four main pathophysiologic mechanisms that cause diaper dermatitis, including irritation, the skin barrier defect, inflammation, and the microbial contamination. Based on clinical studies in pediatric patients aged 3 to 36 months, we know that the novel combination containing zinc oxide, dexpenthanol, taurine, and zinc gluconate have shown to be both effective and safe add-ons for treating and preventing diaper dermatitis. Thank you.
This topic is quite intriguing because we are talking about on base management of atopic dermatitis and contact dermatitis. And this is quite a complicated issue. First, because they are different diseases, and second, because there is a lot of self-made activities. Basing on the management and evidence-based management, I think that we can rely on the two main papers that give us guidelines for atopic dermatitis and contact dermatitis. In this paper, there is a long list of papers and citation and publication that can help us to understand where this information comes from. But reading too is much easier than going through a very abundant literature. The first thing that we have to keep in mind if we want to know which is the baseline management of this disease is that what this disease have in common. And they both have in common the skin manifestation, that is eczema. Eczema is a skin inflammation reaction with erythema, vesicle, desquamation, and itch. But eczema is characterized by two different steps. An acute phase that is an inflammatory phase with spongiosis, associatosis that give rise to erythema, papule, vesicle, crust, itching, and burning sensation, and the chronic phase where the inflammation decrease and we have more an epidermal reaction with acanthosis, parakeratosis, thickening of the epidermis, desquamation, and lichenification. This is very important to keep in mind because this generates different disease manifestation. For example, the acute eczema is characterized by vesicles, by crusting, by erythema, a lot of redness, whereas the chronic eczema is mostly characterized by thickening of the skin and desquamation, or like in this case, lichenification. And they are apparently almost two different diseases just connected from their origin. But what's the origin of this disease? We know that contact dermatitis, allergic and irritant and atopic dermatitis present some kind of different pathways, different signals, and different actors involved in it. In trying to giving a unifying vision of these diseases, we can divide this battlefield in two different areas, two different regions. The first region is what happens above the epidermis, so all the extrinsic factors that could be irritants in irritant contact dermatitis, but which play a role also in allergic contact dermatitis and in atopic dermatitis. That could be antigen, that could be allergen, whatever it is that is in the interaction between the skin barrier and the inflammatory system that is located below. And the second battlefield is the immunologic system, the inflammatory system, where intrinsic factors influence the disease manifestation. We know that intrinsic factors are absolutely obvious and required in atopic dermatitis, so to have an atopic trend, but also in allergic contact dermatitis and eventually also in irritant contact dermatitis, some kind of a personal characteristic can influence the disease manifestation. So if we look at these diseases as a unique situation, we see that we have environmental factor, impaired skin barrier function, and immune inflammatory reaction that are acting and generating all the manifestation. And so how should we act against this factor for management of this disease? First of all, we have to take a general measure and avoidance strategies, especially against environmental factors. Then basic therapy and skin care in order to protect the skin barrier and to restore the skin barrier impaired function. And finally, have anti-inflammatory therapy to reduce the reaction of the immunological and inflammatory system. Let's start from the general measure and avoidance strategies. If we want to set up an avoidance strategy, for sure we need to get an accurate diagnosis. So we need to know which are the specific agents that act in the disease. So we have to make our test, patch test, prick test, etc., in order to know what is favoring and generating the disease. Then a second step that we have always to keep in mind is to keep general measure to avoid skin irritation, like from physical, mechanical factors, chemical agents, biologicals, volatiles, like also tobacco, pollution, etc. So this general strategy may help to reduce the impact of other substances and of skin reaction in this patient. For atopic dermatitis, some are more important, like pollen, dietary intervention, and lifestyle. For sure, they can improve atopic dermatitis, but keep in mind that there are no evidence that the diet is effective in patients that are unselected. So only when it is demonstrated that a substance is causing the disease. So this is a summary of the general measures that we should take to keep the skin in a good quality condition that could reduce and give benefit to our dermatitis, like humidifier, wearing soft clothes, protecting the hands, and having for sure a healthy life with healthy food. As a second step for the skin barrier dysfunction, we have to keep in mind that in all these diseases we have altered lipid concentration and balance that generate an increment in permeability, we have a reduced antioxidant capacity, and this release inflammatory mediators that sometimes are contributing, other times are responsible of the disease manifestation. So for sure, in this situation, we have to take care of our skin with delicate cleanser and lukewarm shower, because the external situation can generate irritation and favor agent and irritant penetration. But also to restore the barrier function through emollients that are very important. Usually an emollient is made of an humectant portion that is for hydration and an occludent portion that is to reduce evaporation and to improve skin barrier function. The emollients are the mainstay of the management of the dermatitis, and they should be regularly applied on the skin regardless the treatment that you want to use. The emollient efficacy is for sure worldwide recognized, and it can heal the disease and help in the disease per se, or they can act as with a steroid-sparing effect, so reducing the need of steroids treatment. What is important to say that today we can find on the market some emollient plus, with plus indicating that along with the vehicle, and there are substances that are recognized to be proactive and effective in the management of the eczematous dermatitis, because they can help skin barrier repair and they can reduce inflammation. Within this, I want to present for sure the new treatment that is the Eczema cream, that is adding a very potent antioxidant furfuryl palmitate to the product. And we had the opportunity to test it on 30 adults with atopic, irritant, and allergic dermatitis, and the results were very good. We evaluated disease score, pruritus, and quality of life, where here in this slide you can see the relevant reduction of the investigator global assessment from baseline after the 28 days of application. The same was for IASI, and there you can see that patients with mild to moderate dermatitis are reduced to having in the majority of cases, over 90% of cases, in almost a clear skin situation, with benefit to the pruritus severity and as a consequence on the quality of life. And this is to demonstrate how the only use of an emollient, and in this case of an emollient plus, can give benefit to the dermatitis. An example, and here another example, in this case a patient with atopic dermatitis. To conclude, we have also to consider that we have some treatments that should be used. Topical steroids class 2 and 3 use in contact dermatitis and atopic dermatitis is absolutely undisputed. Important is to keep in mind that the choice of this treatment should be carefully balanced with the side effect and with the disease status. Also, topical calcineurin inhibitors are possible to be implemented in this treatment, and the other step, other therapies like phototherapy, systemic therapies should be included. And in this case, the situation is getting more and more complicated. The time is over. I just want to remember you that there is a sort of scale in atopic dermatitis that you have to implement different kind of drug with different potency and effect according to the severity of the disease. In this slide, I want to summarize that the management of eczematous dermatitis is a complex management that has always to include life, situation, control, skin barrier function, and treatment strategies that should be implemented all together. Thank you for your attention.
Okay, here we are. Giovanni is already here with us. Stamatis also. Hi, Giovanni. Hi, Stamatis. Thank you very much. And we're waiting for Adelaide. Thank you very much for these great talks. Trying to summarize in a few minutes many important points on atopic eczema mainly. Also, Adelaide is here. Hello, Adelaide. Thanks also to you for your excellent video. Please, just your microphone is muted, so please unmute it so that we can discuss a little bit all together. Great. My first thought is the following. Okay, the skin barrier dysfunction is something that we knew anyhow. Stamatis mentioned the main points. With time, we learned about the role of microbiome. Now, recently, we emphasized, as Adelaide very nicely highlighted, the role of oxidative stress. So, there are several factors contributing, and now we know more, and therefore we try to let's say, to treat as many of them, or to face as many of them as possible. Should we say something about the possibility of individualized treatment? So these factors play the same role in every patient, or there are some individuals in which the one factor is more important than the other, and therefore the topical management should be adjusted accordingly?
Well, certainly we have to design therapies that the patient will use. While we're not yet, I think, at the point where we could do targeted therapy for every patient, I think we learn by taking a careful history, what the patient will tolerate, what the patient will use, what the patient can afford, and getting aligned with those arenas can lead to better therapeutic outcomes. But I believe that because we've developed better products, we're going to have greater efficacy and better outcomes in the management of atopic dermatitis going forward. Understanding the role of oxidative stress, of course, leads us to use products that will address that construct, and therefore educating our patients, educating our colleagues in the realm of dermatology, pediatrics, and medicine will result in a better outcome for those that we care for.
Yeah. So Adelaide, for example, do you think that the antioxidants as part of the treatment would be equally important practically for any patient, or there might be a subcategory in which they make more sense as compared to others?
I certainly think while we can't do a test to discern which patient might benefit most from the oxidative stress interventions, I think, again, increased awareness, better understanding of the pathophysiology will lead to outcomes that are improved. But having a tool such as the emollient with furfural palmitate will allow greater success because we're addressing the oxidative stress. And I think as we try these therapies on our patients, we will learn which patients derive the greatest benefit and direct our therapy accordingly.
Great. Thank you. Giovanni, Stamatis? Any comment to this point, to this discussion?
I agree absolutely that on the fact that treatment should be tailored in according with patient characteristics. So we have also some kind of clinical signs that are more suggestive of involvement of different things. For example, if you have a more let's say localization into the folds with oozing, likely that bacterial involvement is more relevant. If you have more chronic dermatitis, lichenification, whatever, you know that you have an inflammatory cascade that's different from the one that is in the acute phase. For sure, as Adelaide was telling to us, the oxidation plays a central role in the disease manifestation, and also to keep in mind that, okay, you can fight any interleukin that you want, but if you want to restore, for example, the barrier function, and you keep the oxidation going ahead, the barrier function would never be replaced. So probably you can reduce the inflammation, but you don't restore the barrier, because the oxidation of the lipids, direct mechanism of the oxidative effect, or the oxidation that lead to DNA damage and change in production of protein and damage of the protein, will never permit to the cell to restore the barrier function. So it's something that you have to keep in mind, that it's not only one aspect that you have to target. It's a complex disease with different cascades, different factors that act. It's not only barrier, it's not only interleukin, it's not only T cell in the playing the role. So
yeah, exactly. Stamatis, and before you give your answer, maybe I add another point, and then you answer to both of them together. In the era of systemic treatments for atopic dermatitis that we have already ended, should we change anything in our minds toward the idea that we always had, that the topical emollient treatment with antioxidative agents now recently is the cornerstone of management? Does it change anyhow with the introduction with the systemic treatments or not?
No, I don't think that will change. Basic emollient therapy will be just that, basic. It should accompany any pharmacological treatment, and this is not going to change, because even though the new drugs also address points of the epidermal barrier dysfunction, you still need emollients. And as all of you said, atopic dermatitis is a disease with many phenotypes. Many different sides of the body are affected, so we need targeted products, and products that will be affordable to the patients and cosmetically acceptable, so that they will enforce the application every day and achieve a basic result.
Great. There are a couple of questions that we might have a few minutes to address. One is, again, concerning antioxidants, saying that since it's so evident that they are helpful in atopic dermatitis, then is there any potential role for systemic antioxidant supplements in AD management?
Sorry. Adelaide first, you first.
I don't think we have as many studies on atopic dermatitis using systemic antioxidants currently. I do think there is a health benefit to antioxidants, and we have many foods that will supply those. We certainly have seen, at least in the United States, antioxidant use for overall improved skin quality, as well as anti-aging impact, hair growth, regrowth, hair maintenance. But I'm not aware of targeted therapies systemically that deal with atopic dermatitis, but perhaps those will be forthcoming. Meanwhile, we do have topical antioxidants for topical application, and again, we have this wonderful opportunity to benefit our patients in their overall skin barrier repair. So we should take advantage of this timeliness in therapy and these advances in our understanding, such that we can address it at least with the tools that we currently have at our fingertips.
Thank you.
I absolutely agree again with Adelaide. How could you not agree with Adelaide? She's one of the major experts in this topic. So, but it's very controversial, the use of antioxidant as a dietary supplement. But it's evident that a healthy diet is giving benefit. So somehow a connection, it exists, but probably it's also because when you go to a diet, it's a lot of influence. It's how it is absorbed, how it is used by your organism. That it's very difficult to manage and to calculate. What's evident that you can put in a cream, like Eczema did, like other product may have, but it's very essential to think that the emollient is not only something to get the skin smooth and nicer. It's something that is effective. It's a treatment. It's part of the treatment. And when you see the scale that Adelaide showed in the presentation, basic level, you go ahead to another level, you go again ahead and you scale up. You have not to forget to keep going with the basic one. So when you scale up, it's not that you have to remove the base, you have to keep the basement. That's the emollient, hydration, environmental control, whatever.
Exactly. I fully agree. Last point, and then we have to move on. There is a question concerning the skin pH, if there is any role, if it's important, and there are some moisturizers that have been patented based on their ability to lower the skin pH. So do we have any comment on it?
I don't understand the word. Could you say the word exactly that is the concern?
pH.
Oh, pH. Well, we obviously want to have restoration of the pH because that leads to a more stable barrier. And I think that anything that does help with the restoration of the barrier is such a fundamental tenet as we manage patients with atopic dermatitis that we want to work towards that goal. I don't believe we have products right now that fully rebalance the pH, but we again are working towards that. But a good barrier repair, again, one with reduction of oxidative stress, does so much to assist our patients in their quest to have an improved status with their atopic dermatitis. And it's such a fundamental tenet across all the recommendations and guidelines, European, United States, Asian, that we know that our patients benefit when they restore the barrier. Hopefully, as they repair the barrier, the pH comes more in line with the normal pH. And again, their outcome is one that is satisfactory and improved.
Great. Thank you, Adelaide. Thank you, Stamatios. Thank you, Giovanni. And we need to move on because we are running out of time. It would be great if we had some more time for discussion, but I think that we covered most of the topics. So thank you once again. And now, bye-bye. Now we can move on with the second part of this event. We change topics. Now the next part will include various somehow different topics. And our next speakers are Professor Enzo Berardesca from the University of Miami in the States, together with Maurizio Cavallini from Milano in Italy, speaking on melasma, what's new? Quite interesting. Then Marina Papoutsaki from the Sigros Hospital in Athens in Greece on hyperkeratosis in dermatology challenges and treatment, followed by our last speaker, which will be Professor Giuseppe Micali from Catania, from Sicily in Italy, who will have two consecutive talks. The first on Urea, with its proven clinical efficacy in dermatology, what's new on it, and finally, management of acne clinical update. Again, in the end of the talks, we will have the chance to have a live discussion, and again, of course, you can send your questions throughout the event. So see you in approximately 30 minutes, and we can start with the videos.
Good afternoon to everybody. Now we move to melasma. You know that melasma is a quite difficult condition to treat, and I'm going to present the results of a study which has been published last year in the Journal of Cosmetic Dermatology. Here you can see the paper, and the study is an in-use test for which detects the efficacy of a treatment based on kojic acid for melasma. Treatment was a regimen, including a night cream, a day cream, and a cleanser in patients with phototype 1 to 5. 100 patients entered the study. These were women affected by melasma, age around 45 years old, and all types of melasma were included in the study, epidermal, dermal, and mixed. The degree of melasma was evaluated using a clinical score by the investigator, the modified MASI, and the investigator global assessment. These scores were evaluated after 45 days and 90 days of the treatment, and for the MASI at the baseline, of course. At the end of the study, there was a satisfaction questionnaire which was filled up by the patients in order to perceive the satisfaction of the treatment. Here we can see a picture of a melasma. The name is Pigment Solution Program. It's a program based on a cleanser, a day cream, and a night cream. The cleanser is a mild cleanser, which has the specificity to induce a gentle cleanse of the skin and prepare the skin for the treatment. And the day cream is one of the pillar of the treatment. The day cream is composed by vitamin A in order to induce a cell renewal to promote the mild desquamation. The formulation contains kojic acid in order to induce a lightening action, and also a moisturizer, aquaxyl and tocopherol as an antioxidant in order to protect the barrier and regulates transepidermal water loss. The night cream provides a double peeling effect, chemical and mechanical. The chemical was obtained by kojic acid and glycolic acid associated, and mechanical by a biodegradable scrubbing beds. All these ingredients were tested in a previous study, have shown the reduction of intensity of the pigmentation in vivo of 14% and the reduction of the dark side spots of around 7%. The reduction of a MASI score, of a modified MASI score, was obtained at 45 days and 90 days, respectively, of 34% and 64%. Interestingly, if we split the data, we can see, and we evaluate the effects on each type of melasma, we can see that the major improvement is obtained in the dermal type of melasma, which is usually a very difficult condition to treat. So the expectation of this treatment are very, very good. Here we can see the effects on epidermal and mixed melasma around 60% and dermal 82% of reduction. The investigator global assessment improvement was very well obtained, and for marked improvement, moderate improvement, and very strong improvement. Overall, we had the improvement between 80 and 90% of the patients. Here is a clinical picture where you can see melasma before treatment and after treatment here on the upper lips. This is a picture under UV in order to reinforce the pigmentation, and you can see the improvement in the dark spots over the lips after 90 days of treatment. Skin tolerability was very good, and almost 99% reported good or very good or excellent skin tolerability after both 40 days and 90 days. So in conclusion, we can say that melasma is a difficult disease to manage, and there are no standard therapies, and this regimen is very interesting and encouraging in terms of efficacy, safety, and tolerability. Thank you very much.
So good morning, everybody. My name is Maurizio Cavallini. I am a plastic surgeon from Milan, Italy, and I would like to focus my presentation on the management of hyperpigmentation, because we know that we have a lot of things to use in hyperpigmentation, like sun protection, oral agents, or some devices like laser or IPL. But I would like to present to you today the possibility to treat the hyperpigmentation with chemical peeling in combination with topical cream. And I'm proud to show you the study that is going to publish on Journal of Cosmetic Science 2020, in which I treated 7 patients with dark spots, melasma, or post-inflammatory hyperpigmentation, combining the treatment between Definis lightening peel procedure and pigment solution program in an open label study. I had 2 endpoints. The primary endpoints was to evaluate the reduction of hyperpigmentation by a topical cosmetic treatment after performing a chemical peeling. The reduction was evaluated with the digital analysis of cutaneous surface, the DAX, that is measured with a special 3D camera in which you can use the same area, about 6 square centimeters, to be evaluated before the chemical peeling, after the chemical peeling, and after the end of the study with the use of the pigment solution program. Is a very objective way to recognize the improvement in the evaluation of the hyperpigmentation. The secondary endpoint was to evaluate the safety and the tolerability of the cosmetic treatment. And moreover, the overall evaluation of both the investigator and the study subjective satisfaction. The treatment was administered at home for 30 days, and before the home care treatment, we performed chemical peeling. The chemical peeling was performed with Definis peel program. It is a very successful treatment performed with 3 different acids, salicylic, pyruvic, and retinoic acid, 2 ingredients that are able to contribute towards the brightening of the skin spots, plus the presence of 2 other substances, Lumiskin and a lipoamino acid called Sepi White, that are able to reduce the appearance of hyperpigmentation. After the use of this type of peeling, we suggest to the patient to treat the dark spot with pigment solution program. That is a kit in which you have a cleanser and you have a day and a night cream to treat the dark spot. And the results were very interesting because using the pigment solution program, we have a very statistically significant reduction, by 5%, in the melanin percentage of dark spot. But if you note this picture, you can see that if we combine the treatment with a chemical peeling with Definis peel program lightening, we have a percentage change that increased by almost 3-fold between the pre-peel period and the end of the study. And so you can see the results before the peeling on the left, after the chemical peeling in the middle, and after the application of pigment solution program on the right. And you can see that the DAX is able to describe also the percentage of improvement, as you can see in this picture, and also under the 3-dimensional reconstruction, the final results in the reduction of hyperpigmentation. So in conclusion, I think that it's important to underline that if we can combine the chemical peeling plus the use of pigment solution program, we can have a very good results in the improvement of the reduction of dark spot and hyperpigmentation. Thank you very much.
Dear colleagues, I would like to welcome you also in this webinar event. It's a rather unusual way of communicating, but let's say that the last month, this is the only way we have. We will have the chance to talk on the next moment about hyperkeratosis. We know that skin is the most extensive organ of the body, and its, let's say, its structure and its thickness may vary according to the anatomic site which is present. And therefore, also, the effects that hyperkeratosis has may vary. Let's focus now on hyperkeratosis, which is a histopathological term defining a thickened stratum corneum and may be present in many different skin conditions with many possible overlaps. Hyperkeratosis can be associated with dyskeratosis, which is a premature or abnormal keratinization of individual keratinocytes, or with other abnormalities in the skin biopsy, such, for example, with epidermal hypertrophy, a benign alteration of the skin that presents with acanthosis and hyperkeratosis. It can be due to several exogenous as well as endogenous processes, and it is related to increased production of keratin at the outer portion of the skin layer. It is mostly due to chronic physical or chemical damage, for example, friction, aggressive soaps, or tattoos, chronic inflammation, like in case of psoriasis or atopic dermatitis, side effects of different drugs, chemotherapeutic drugs, immunomodulators, and the most recent immune checkpoint inhibitors, and to nutritional deficits. The most frequent one is lack of vitamin A. Regarding the epidemiology, the incidence is unknown, as hyperkeratosis is the histologic aspect of many different pathologies, both benign or malignant. We can distinguish two types: the orthokeratotic type, which is characterized by thickening of the keratin layer with preserved keratinocyte maturation, and the parakeratotic type, which is characterized by retained nuclei as a sign of delayed maturation of keratinocytes. We know that the stratified epithelium is in a constant process of self-renewing and exfoliation that takes 20 to 40 days to complete. The cells in the outer layer are the most differentiated in the keratinocyte line, composed almost entirely of keratin lamelles of high molecular weight. Those keratinocytes are the ones that undergo desquamation, completing the maturation cycle. When the epidermis is exposed to repetitive injury, it is usually elicits an increased proliferative rate of keratinocytes and accelerates their maturation. Keratinocytes also tend to produce more keratin, thus increasing the stratum corneum's thickness. Acute injury results to edema, which is translated into spongiosis, while chronic injury results in epidermal hyperplasia, resulting in acanthosis, accompanied by ortho or parakeratosis. Genetic mutations can also result in hyperkeratosis, as it happens in ichthyosis and keratoderma, where, for example, genes KRT1 and 2 are mutated. And therefore, histopathology varies according to the reason, the cause of the hyperkeratosis. Unfortunately, we don't have enough time to go through in detail, but we do see different histopathology if it happens to be mechanical hyperkeratosis, or psoriasis and psoriasiform dermatitis, interface and lichenoid dermatitis, verruca vulgaris and plana, seborrheic keratosis, ichthyosis, and squamous cell carcinoma. If we try to translate this in our clinical applications, and here we see the tree of dermatological diseases, we can see that hyperkeratosis can be present in different kinds of the diseases of the dermatological spectrum, let's say. We can have it in non-infectious diseases like papulosquamous diseases or autoimmune diseases. We can have it in infective diseases like fungal diseases, malignant or benign neoplastic diseases, or others like genodermatosis. And here we see a list of the most common ones, and we find among them simple, let's say, diseases like callus and corns, then keratosis plantare, chronic folliculitis, more complex inflammatory diseases like atopic dermatitis, psoriasis and psoriasiform dermatitis, lichen planus and lichenoid dermatitis, keratosis pilaris, ichthyosis, seborrheic keratosis, actinic keratosis, keratoacanthoma, paraneoplastic syndrome, squamous and basal cell carcinomas. And we all come to see in our daily clinical practice images like this that are the result of these different diseases in hyperkeratosis in the skin, which is now the prognosis and can be the complications of a hyperkeratotic feature. The prognosis is related to the specific dermatological disease that is causing hyperkeratosis. It usually improves with treatment, but in some cases might be persistent and it can relapse. Therefore, patient has to be informed about this. Moreover, the cosmetic appearance of hyperkeratosis, especially when exposed areas such as the face, scalp, and neck are affected, may cause significant psychosocial distress and therefore affect the quality of life of the patient. Moreover, scarring secondary to the traumatic manipulation of the lesion from the patient can occur. It is important for the diagnosis to get a very detailed history. History and clinical evaluation play a very important role, and the main goal remains to collect as much information as possible in order to arrive in a correct diagnosis and therefore to the most appropriate treatment. In some cases, clinical diagnosis may be sufficient, while in other cases, a biopsy, dermoscopy, or patch test can be useful for the diagnosis. Into the history of the patient, we should include the following information: the age of the patient, family history, exposure to toxic substances or drugs, occupational duties, anamnesis of the current lesions, as well as concomitant diseases and treatment. Regarding the management of hyperkeratosis, patients should be educated that basic skincare measures such as hygiene, hydration, exfoliation are important to maintain functional skin even in the affected area. Instructions for the other precautions should be given based on specific dermatological diagnosis. This is normal to think of. Initial treatment usually consists of emollients and topical keratolytics such as salicylic acid or urea, and the patient is being re-evaluated. In the case that there is no response to general topical measures, then depending on the diagnosis, therapy can include either topical corticosteroids or vitamin D derivatives, as well as retinoids, topical anti-inflammatories like calcineurin inhibitors, phototherapy, laser treatments, immunomodulators, or even surgical procedures. So, in conclusion, we need to say that hyperkeratosis is a complex histopathological term defining a thickened stratum corneum and may be present in many different skin conditions with many possible overlaps. Patients, therefore, should be educated that basic skincare measures is of great importance. They are of great importance as a first-line treatment and in monotherapy, but also in combination with other topical, pharmacological, or systemic treatments. We must say that emollients and keratolytics play a very important role in the management of hyperkeratosis, and we will have the chance in the next presentation of Professor Mikhaili to see the role of urea, which is one of the most commonly used keratolytics and emollients to this kind of affection. And with this, I would like to thank you for your attention.
Hello, Aimilios. Hello to everybody. Thank you for your kind words, Emilio. Today we will talk about the urea, a century of proven clinical efficacy in dermatology. What is exactly urea? Urea is a polar hygroscopic molecule produced by the human body that plays an important role in the metabolism and excretion of proteins. Urea is part, almost 7% of the component of the natural moisturizing factor known as NMF of the stratum corneum, thus playing a key role for the maintenance of skin hydration. Historically, urea is a compound that has been used for more than a century in dermatology, and it is known to be effective for conditions associated with dry and scaly skin. Importantly, when used at a different concentration, urea may exert different action. Namely, if you use a low concentration, below 10%, may have a different action compared to higher concentration, where is more than 10% of a urea concentration. Let's just start to discuss a little bit about the therapeutic properties of urea at low concentration. Low concentration, below 10%, urea exert a moisturizing action. How? Urea acts as an humectant, which means attracts and retains water in the stratum corneum. It's also able to attract water from two sources, the dermis and in human condition, the external environment. Let's take a look to what is the mechanism of action of urea at high concentration, more than 10%, keratolytic action, which is done through the fact the urea induces protein conformational changes by breaking hydrogen bonds, reducing cohesion of keratinocytes. So keratolytic action when it's more than 10%, moisturizing action when it's less than 10%. Based on these different properties, there are a variety of skin conditions in which urea can be used, from xerosis, ichthyosis, atopic dermatitis, psoriasis, diabetic foot onychomycosis, keratosis in general, seb care, contact dermatitis, radiation-induced dermatitis, sorafenib-induced skin reaction, dystrophic nails, tinea pedis, pruritus, and many more. And interestingly, basing on these different mechanisms of action, different formulations are available of urea, and that include concentration that may vary from 2% to 50%. On your left side, you will see the different formulations which are available all over the world. Lotion, emulsion, solution, cream, gel, foam, ointment, nail lacquer. So normally, it is better to classify the action of urea in low concentration, which is related to 2 to 10%, medium concentration 15 to 30%, high concentration 40 to 50%. Remember that the more urea concentration we use, the more are the chance of potential skin irritation. So between 2 and 10%, the chance of irritation is very minimal. Of course, if you go to 40 to 50%, patient may experience some stinging, burning, or some redness, which is, however, temporary. Let's just take a look to low concentration. What is the evidence in literature on the use of urea at 2 to 10% in xerosis? Several randomized clinical trials support the efficacy in urea in the treatment of simple xerosis and in xerosis related to disorders with the inability of the stratum corneum to maintain hydration, such as ichthyosis, atopic dermatitis, and psoriasis. All of these RCTs has been based on clinical assessment, on instrumental evaluation of TEWL and stratum corneum hydration. There are 11 trials on ichthyosis, which shows that urea at 2 to 10% is effective and well tolerated. And here there is a study that we have conducted in my department with a 10% urea emulsion twice a day for 30 days in 5 patients with ichthyosis vulgaris. And we did video dermoscopy and confocal microscopy evaluation. This was a preliminary study. All patients showed an excellent response with significant clinical improvement of xerosis and itch. This is a clinical image of one patient at T0, at baseline score 3, and after 6 weeks, we see that is scored 0 with complete clearing. And also you can see at dermoscopy on the upper part of the slide, you see the scales before and the absence of scales at the control, which we evaluated as scored 0. Same with the confocal on the bottom of the slide, showing normalization of furrows, sides, and morphology. And so baseline is on your left and after treatment on your right. Always talking about urea low concentration, also in atopic dermatitis, is pretty effective. 11 trials associated or not with corticosteroid, effective and well tolerated. And remember that in atopic dermatitis, the basic therapy is very important and is based on moisturizers. And most of the moisturizers that are in the literature are urea based. So this is perfectly in line with all the current guidelines for treatment of atopic dermatitis regarding basic therapy, which is a very important step in the management of these disorders. This is a systematic review again. It's confirming what I was said before. Among different type of moisturizer, the clinical effectiveness appear most well documented for urea-based preparation. And this is another meta-analysis that we did on atopic dermatitis treated with topical moisturizers, and we evaluate 92 randomized clinical trials. The efficacy moisturizers containing urea have shown the greater evidence of efficacy. Concluding the range of possibility to treat disorder with 2 to 10%, also xerosis of the feet may take a lot of advantages by using urea, a low concentration. Diabetic patient have a high incidence of cirrhosis of the feet with the increasing risk of ulceration. Urea is safe and effective. Moving to medium concentration, hyperkeratosis. Medium concentration can be used in case of low to moderate hyperkeratosis involving large areas, as in this patient that you see on your left. Of course, we have always to balance the keratolytic action with the possible skin irritation. And again, other cases out from our department, urea 30%, cream for 2 weeks in the ear, you see, and around the belly, with complete disappearance of hyperkeratosis, which facilitate also the use of the appropriate pharmacological treatment. Moving to high concentration, 40 to 50% hyperkeratosis, chemical nail plate avulsion. You see here, useful in case of severe hyperkeratosis involving small areas, as you can see here. You see here, urea cream 50% for 2 weeks. Some of these hyperkeratotic lesions are very stubborn. This is a clinical study we did on 25 patients with plaque psoriasis with evident hyperkeratosis component, a 50% urea anhydrous paste twice daily for up to 3 weeks, clinical assessment and high frequency ultrasound, clearance in 92%, no side effect, and baseline after 2 weeks. Great result, as you can see here, complete disappearance of hyperkeratosis. And ultrasound showed a significant reduction of the mean epidermal thickness, approximately 50% reduction, reaching a thickness similar to normal epidermis. Here we are at baseline and here after 2 weeks, with a thickness similar to the normal epidermis at ultrasound. Finally, urea can be used also for chemical nail plate avulsion, nail dystrophy, onychomycosis, psoriasis, or in case of pachyonychia or onychogryphosis, as you can see in this. But usually in these cases, 40 or 50% should be treated under occlusion. Remember also the urea can be used as a penetration enhancer in onychomycosis combination treatment of 20 to 40% urea with antifungal agent and be shown to be superior to monotherapy. This is my last slide. Again, low concentration, 2 to 12%, xerosis, ichthyosis, atopic dermatitis, psoriasis, xerosis of the elderly, medium concentration, mild to diffuse xerosis, hyperkeratosis, is in psoriasis, chronic eczema, etc. Hyperkeratosis localized in sensitive areas, face, genital area, and high concentration, moderate to severe, localized hyperkeratosis, psoriasis, calluses, warts, keratoderma, etc., or nail plate avulsion. Conclusion: despite the new continuous discovery of new compounds, urea is still one of the most useful molecules in the end of dermatology. Urea-containing products are available at different formulation and concentration, providing several alternatives for the management of many skin conditions. Urea products have generally few adverse effects, and there are no reports of sensitization despite its widespread use. Thank you for your attention. So it's me again, Aimilios. Thank you for your kind words again. My last talk and the last talk of the session. Acne management clinical update. See what's new. We all know what is acne. Is a chronic inflammatory disease. It's common in early adolescents, rare in pediatric and adults. Many different clinical presentation. Those are the clinical hallmarks of acne: non-inflammatory lesion, closed comedones, open comedones, an inflammatory lesion which consists of papules, pustules, and nodules. Its prolonged course may lead to scarring and cause significant disfigurement that severely impacts the patient's life with emotional sequelae, negative psychological impact, reduction of quality of life, negative social perception, and also body imaging disturbance. So the message is that we should start to treat acne as soon as possible in the best way. Those are the agents that are available: retinoids, antibiotics, antimicrobials, systemic agents like retinoids or antibiotics, hormones, other topical agents. Pharmacological treatment remain the main approach for almost of clinical type, but remember that its use may be associated with adverse reaction, side effect, which affect the patient compliance and decrease the adherence. So those are a list of the most common topical agents for acne. As you can see, all are associated independently if there are retinoids or BPO or antibiotics may still cause erythema, scarring, burning, flare, resistance, and photosensitivity. So in the last 5 years, there's been a lot of interest on cosmetics and cosmeceuticals play an important role in acne treatment, minimize common stratum corneal side effect from systemic topical retinoids, BPO antibiotics. If correctly prescribed and used, may have a synergistic effect with pharmacological agents. There is a lot of papers and articles in the literature confirming the efficacy of cosmetic and cosmeceuticals in acne. So this is our experience with a salicylic acid-based product for the treatment of mild comedonal papular acne, result from a recent multi-center prospective observational study. This is a new acne daily regimen, principally consisting of a cleansing gel, which is considered a cosmetic, with 2% salicylic acid, urea peroxide, and glycolic acid. Then we have a moisturizing gel in the morning, which is a cosmeceutical or medical device, better to define. Salicylic acid 2.5, nicotinamide, saccharide, isomerate, vitamin E. And then we have a purifying gel, again, another medical device to be used at bedtime, again, salicylic acid, zinc taurine, urea peroxide, vitamin E. 4 center, Ferrara, Milano, Naples, and Catania, adult acne, mild inflammatory, comedon, and inflammatory acne, washout period of at least 4 weeks for topicals and oral antibiotics, wash out at least 3 months for oral isotretinoin. Material and methods: clinical assessment, so total lesion count, baseline after 4 and 8 weeks, investigator global best assessment at 8 weeks, instrumental evaluation with erythema directed digital photography, VCR, and then patient assessment for VAS, for patient discomfort, and tolerability, acceptability at 4-8 weeks. Patient 41, 28 female, 13 males, around 20 years of age, number of non-inflammatory, inflammatory lesions at baseline, blackheads, 16 plus or minus 16, papules around 8 plus or minus 4. At week 4 and 8, a significant reduction of non-inflammatory inflammatory lesion compared to baseline was observed. Comedones 16 at the baseline medium range, 14 4 weeks, and 8, so half after 8 weeks. Papules 7.9, almost 8, versus 6.4 versus 4, again half of the papule count, also at 8 weeks with the statistical significant values. Overall assessment of clinical outcomes at weeks 8, EGA showed great improvement, 40% of cases, improvement in 26 of pairs of cases, mild in 20, worsening and unchanged in 10. Patient discomfort related to acne, significant reduction of VES, score at 4 and 8 compared to baseline, confirming that the patient of discomfort was minimal. The tolerability and acceptability at week 8 was 90% excellent, and acceptability was 97% excellent. Those are some cases at baseline. After 4 weeks and 8 weeks, we may probably better see at with Visia, with especially in the forehead, complete disappearance of the lesions. Another case after baseline, as you can see at 4 and 8 weeks, very interesting results. And another case at 0 after 4 weeks and 8 weeks, again, you see that all the inflammatory lesions are gone and we have only residual post-inflammatory hyperpigmentation. So the mechanism of action of the main ingredients, the efficacy, in my opinion, is related to synergistic action of all active ingredients: salicylic acid, keratolytic, decrease inflammation; nicotinamide, sebum controlling, decrease inflammation; urea peroxide, antiseptic against P. acnes; glycolic acid as a keratolytic; zinc taurine, again anti-inflammatory; saccharide isomerate is a moisturizer. So all of these different compounds act on 3 of the pathogenetic factors of acne. Conclusion: the results indicate that this combination represents an interesting approach which undoubtedly deserves attention. When to use? Okay, this is the most important part. Mild inflammatory acne in patients that prefer to start with a non-aggressive treatment, in association with conventional therapy in patients with good tolerability as a maintenance treatment. So please keep in mind that it's not photosensitizing and may be used also during summertime. Thank you for your attention.
Okay, here we are again. First of all, I know that many of you might experience some problems with the transmission until now. Me myself also experienced some problems. Of course, we're sorry about it, but it's not definitely neither my fault nor the fault of the speakers. But in any case, the good news is that all this session has been recorded and the videos will be sent to you, and also they will be available in the European Medical Journal. So in case you were not able to follow something, or in case you missed something, either through during the presentations or during the discussion, you will be able to go back and check the discussions again. So hi friends, Dr. Cavallini is here, Dr. Berardesca is here. We're still waiting for Marina and for Giuseppe. But already I have some questions, but they are mainly for Dr. Micali, so a little bit later. Enzo, may I ask you, great presentation, thank you very much. So what would be your strategy today for, let's say, a classic case of mild melasma. Let's not speak about extreme cases, the classic case of mild melasma. Would you still go on first with the classic first-line option, the Kligman formula, and then change to this?
Yes, you know, the Cleveland formula is not available everywhere, and so because hydroquinone is not available, so you, at least in Europe, we have to go with standard formula with our solution. So this is approach of a multi-centric, multi-synergistic approach, including kojic acid, an antioxidant, some alpha-hydroxy acid in order to increase the squamation, could be very successful in order to, especially for mild cases, but even in the long term, in association like Dr. Cavallini reported with stronger treatments like peelings and so on, or laser treatment associated with photoprotection could be very successful.
Yeah. And do we also have data as a maintenance treatment after Kligman formula?
Yes, of course, because it's, since it's not irritating and very well tolerated, no irritation, no allergic reaction, yes. It could be a long-term maintenance treatment, yes.
Great. Without any restrictions in the time frame, in the duration?
No.
Okay.
Not as far as I know.
Yeah, not as far as we know for the moment.
Yeah.
Also, Professor Micali is with us.
Hey, Aimilios. Nice to see you.
Nice to see you too. Thank you very much for your great presentations. Let me tell you that already we have a couple of questions for you.
Okay.
Can salicylic acid preparation be used for nodulocystic acne patients?
Okay,
So,
can you say it again?
Yeah. The salicylic acid product that you presented, can you also use it in more severe cases of acne, like cystic acne or?
You mean urea, right? The
salicylic acid.
Oh, the salicylic acid. Okay. Talking about acne.
Acne.
Okay. That is 2% only, 2.5% only. So at that point, probably may be a very mild effect. I wouldn't not use on severe acne.
But Giuseppe, let me also ask you the following point. One of the problems that we often face practically when we treat acne only with local agents is the fact that we anyhow have to prescribe several products, and this is maybe a reason why you don't want to apply also additional cosmetic products, because then it becomes too much for the patient to use so many different products. So which would be your approach on the best combination of local drugs with cosmetics?
Okay, very good question, Aimilios. The point is, number one, I agree with you. Sometimes you don't want to prescribe too many products. This is something that I always think about it. But of course, you cannot give a systemic treatment in a patient who is not eligible for systemic treatment, right? We have to follow what are the guidelines, and for a mild acne, it doesn't make any sense to give a systemic antibiotic, so forth. So you have to comply with the drugs and cosmetics. Keep in mind that cosmetics may also, I would say, control the side effect from topical drugs for acne. BPO, retinoids, they all are irritating. And they have to go through the irritation in any case. So what I will do, I use a fixed combination normally, which is one product only, which is up to you, up to me, if you want to decide BPO and retinoid or BPO and clindamycin or whatever. And then I use a moisturizing agent or a soothing agent as a cosmetic. So at the end of the day, and of course a cleanser. So at the end of the day, I have 3 products on: cleanser, systemic topical drugs approved for acne, and a cosmetic which may smooth and may soothe the skin. The point is different when you, like in the case we presented with salicylic acid, those are for very mild acne, in which most of the patients, they don't want to go through a topical drugs, which is very irritating, or they ask for something very light. And at that point, as you can see, that formula, which is consists of cleanser and 2 cream, day and night, it works fine. You know, for mild comedonal acne, I think it's okay.
Yeah, I guess that also it would make sense for other types of folliculitis of the trunk.
Yes, yes. You mean acne of the trunk?
Yeah,
or any type of folliculitis. Yes, because salicylic acid, as you say correctly, has also have some antibacterial properties and keratolytic properties. So it may make sense to use in some folliculitis, especially 2% or 2.5% is not irritating at all, so it can easily use it.
Yeah. Thank you.
Thank you.
Marina is also with us.
Hello, everybody.
For your great presentation. Hyperkeratosis is just, such a big chapter because, as you showed, there are so many diseases that are typified by it. Just let me ask you, how do you select usually the way that you're going to face a hyperkeratosis? If you're going to use just high concentrations of urea, or if you add also salicylic acid, or anything else that could act keratolytically, or it doesn't matter in the end, use whatever you like and then the hyperkeratosis will eventually go?
No, I think it needs to be patient tailored. You saw that it's a vast area. So even within the same disease, you need to use different products. It will be different, for example, in psoriasis, whether you need to treat a thick plaque or you just need to use it in an emollient way, for example, urea. So it needs to be person tailored. It's related with the disease. Of course, the compliance of the patient is always very important. How long he's willing to do the treatment. If he wants to put creams on, how greasy they will be. They don't need to be sticky or smelly. So sometimes you even give something less from what you would like for longer periods, but this will help patients comply and then apply the cream, because the question is to apply treatment. There might be a perfect treatment, but if the patient is not using it, it's useless. So I think we cannot give a rule for everybody. But as we can see, we can play around a lot because we can use different vehicles for the different substances, keratolytic substances like urea, for example. We can use different concentrations and according to what we need to treat, and this is very important.
Absolutely. Great, thank you. There is one more question again for Professor Micali, which is, Giuseppe, in the study that you showed with the urea cream, did the result was observed only with the urea cream or in combination with corticosteroids and calcipotriol?
No, the study was designed to see how effective was urea per se. So it was urea only. We did not mix with any other drugs. So it was 50% urea for severe psoriasis.
Yeah. Great. Okay. Any other comment that any of you would like to make? Dr. Cavallini, maybe?
Emilios, I would like to show you the importance also of the peeling, not the lightening, but the classic peeling in the treatment of acne, because you know that there is a combination between salicylic acid and also with pyruvic acid is an important seborrheic agent. And I think it would be a very good tool to treat also the acne in combination with other agents, as Professor Micali showed us. And I personally treated also some folliculitis in the body, for example, with chemical peeling, because the presence maybe of salicylic acid is not irritant, and it could help to give good the inflammation of the folliculitis of the body. So it could be a good device, a good tool to treat both acne and folliculitis.
Absolutely, absolutely. Okay, great. I think we are a little bit out of time. So thank you all very much for your great presentations and for the availability to be here live with me for this short discussion. I hope that we were, of course, not able to cover everything in all these topics, but the main points that we wanted to raise, I think that have been sufficiently covered. So thank you all very much once again. And to the participants, thanks a lot for being here. Thanks a lot.
Thank you, Emilios. Thank you to everybody. Bye-bye.
Bye-bye.
Thank you.
Thank you, dear participants, for spending this hour and almost 2 hours with us. I apologize again for the technical details. I repeat, you can find the videos without interruptions and problems, so you will have access to the full content. And thanks once again to Menarini and to Real Life for organizing this event. I hope that the participants enjoy it and find it useful for their daily practice, because in the end, this is what matters. So
thank you. Bye bye.
I think
ciao, Enzo. Bye bye.
Ciao. Ciao.
Bye.
Bye. Thanks once again to all the speakers and to all the participants. Goodbye.